Hey, Josh.
Yeah.
So, what if I saw you acting a little bit weird?
Yeah.
Which is kind of normal for me.
It is.
All right. And I walked up to you and I said, Josh, I'm going to give you a shot so you don't act like that. And stuck it in your arm.
Well, right now, that would be assault. I'm pretty sure that would be assault.
And that's what we're talking about with involuntary admissions.
We're going to talk about something very popular, at least in discussions right now. There's a lot of momentum for it. Involuntary hospitalizations. And the scenario that KK just described, we're going to talk about under what conditions that should be possible and legal.
This is Untangling Knots, where we break down complicated homelessness topics like this. Today is episode 4, Involuntary Admissions. Who makes medical decisions for the homeless? How about we untangle these knots?
Disclaimer. The views and opinions expressed on this show do not necessarily reflect those of me. No, definitely they reflect those of me. Only me.
Only you.
They don't reflect those of necessarily my employers, of my team, of my supporters, of anyone but me. If you have a problem with this, just come to me. Thank you.
The same is true for me. If you have a problem with anything I say, questions, take it to Josh.
Take it to me. I'll take it to Josh. All right. So this is a huge topic. And since I probably have the most medical experience here, I'm going to lead the conversation. So Care Beyond the Boulevard is an indispensable nonprofit in Kansas City. And what Care Beyond the Boulevard does is, and they're the only ones in Kansas City that have done this. They really, for this city and this region, invented this. They go into encampments and they provide the highest level of medical care that is possible. They have had in their history huge buses they've converted into mobile medical offices. Now they have a really like a newer one. But not only that, they have clinics all over Kansas City, walk-in clinics, no appointment necessary. So a medical provider seeing folks that are chronically homeless, no one is seeing more than KK and her team. No one in Kansas City. She has the most experience with this population of anyone in the city when it comes to medical decisions. So when she's going to give an answer, the perspective is going to be she is in this work every single day. And then I am going to, from my position, I'm going to talk about why communities are looking to this as a solution. Not saying it's right, not saying it's wrong. I'm saying this is what I think they're thinking. So let's start. KK, can involuntary holds work today? And here's what I mean. The current infrastructure that exists right now, the current insurance structure that exists right now, medicine, all of that, all the rules that are in existence right now, would they work to do involuntary holds if we just started doing them?
No. And there are a lot of reasons why, and you mentioned some of them. I think that it's really important for people to understand how involuntary holds work.
Yes.
Right now. So what happens is somebody presents as a danger to themselves or to others, sometimes as a public nuisance.
Yeah.
And someone says, okay, they need to go to the hospital and they need to be admitted. The process then is people who want them treated, taken care of, have to fill out affidavits. It's this piece of paper that says why they need to be admitted to an involuntary hold. Now, different states have different laws as far as how long that involuntary hold is. It's between 72 and 96 hours. So in the state of Missouri, it's 96 hours. The state of California, it's 72 hours. So that involuntary hold, after that time period is over, then what happens? What happens is either the person is released back home or in our patient's case, back home
for the
to the onto the street, right? Or the medical provider, the psychiatrist, the psychiatric mental health nurse practitioner, the counselor, whoever is working with them professionally, they say, you know what, I really feel like they need to stay longer. They can extend that hold, but oftentimes then you have to get the court involved.
Oh yeah.
In order to do that. It's a lengthy process. The individual is allowed or has a right to, I think it's more appropriate to say, has a right to legal counsel to help defend them if they do not feel that they need to be admitted, or if they don't feel like the admission needs to continue, if they want to defend them being dismissed. So it's a very lengthy process and expensive.
Yes.
It's very expensive. It's expensive from a insurer's standpoint, but also from a community standpoint, because we're talking about the legal system, and we're talking about for our patient population, we're talking about people who really don't have the funds to hire a lawyer. And so they're allowed, they have the right to have someone to defend them, which means it's a lawyer who is appointed to them, and they're not paid. Who were they paid by? I don't know. Like, that's a question.
Like legal aid.
Exactly.
Yeah.
Exactly. So it's paid for by the public. Yeah, for sure. So that's how that works now, or doesn't work now. It doesn't work. And it can work for people who are in crisis.
Yeah, like the logistics of how hospital systems work now. Let's say someone experiencing homelessness comes in on an affidavit, on a hold. A hospital intrinsically is thinking to themselves, look, and I know they want to help people, but there's the people behind the people who are helping, and they're thinking, what is the billable hour that this, whatever the term, the CPT codes, however you want to look at it. What is this person worth? How much are we spending on this person, and how much are we going to get back? When they see someone experiencing homelessness who isn't connected to any kind of healthcare system like Medicaid or regular non-state funded insurance, that number is zero on terms of what they're going to get back. And the number in terms of how much care is going to be very high.
Well, and even for people who have Medicaid, we know that about 75% of the patients that we take care of in street medicine are insured. But what is the reimbursement for
Medicaid's
Medicaid?
uninterested in paying for this. They're not going to want to. They're going to find every way not
Exactly.
to. And hospitals are not going to want. 96 hours is on the furthest end. When I filled out quite a few of these, and it's always been around suicidal ideation. The longest someone was in a hold was 8 hours. 8 hours, and then they're going. Like, the hospital system right now is in no way equipped to deal with this. It's not a question of it's not possible with the current system. And the other thing, and I know people got really excited when the current administration started talking about involuntary holds. Excited on one end or the other. On the end that's wanting this to happen, the question I have, and I also have this with activists who are really scared about this, where the hell are they going to put people? There's nowhere to put folks.
No.
And I can't think of something more expensive. So shelter is the most expensive form of housing. Until we start doing this will be by a mile the most expensive way we have ever decided to address homelessness, probably by a factor of 50.
Well, and it's not addressing homelessness. I mean, let's be real. What it is moving people out of the way so we can't see them.
Exactly. That's addressing homelessness.
That's not addressing homelessness.
It's a really good way to do it.
What happens when they're at the end of that hold or at the end of that admission?
They're fixed, obviously.
They're not.
That's the goal.
That is the goal. That is the goal. And the issue with that is that in order for people to have their illness addressed, it's ongoing. And when they're dismissed from whether it's 72, whatever the time period is, as it is right now, when they're dismissed from that, where is their psychiatric support? Where is their ongoing
You make an appointment.
Right.
And you show up.
And you make an appointment and you show up.
Let's talk about that.
You really want to?
Yeah, so like when we're saying like can involuntary holds work, the process is going to be, and I think in the minds of folks who are not in this field, what they're thinking is, okay, someone is not able to make decisions on their own. You put them in the factory whips them into shape, fixes them, points them in a direction, gets some momentum, and then that momentum carries them on into permanent housing.
Not quite.
Is that how it works?
Think about it in medicine. No, that's not how we think about it. But
how does it really work?
Well, so when you have an involuntary hold, the idea is to help figure out what's going on. And
let's use a specific example. Let's use someone with schizophrenia, 21 years old, very young.
Okay.
Did a break-in, didn't really know where they were, didn't steal anything, just broke into a place. Police show up. Person is clearly not well. They do a test. There's no substance use. It's clearly some kind of episode.
Okay.
That's the patient.
Okay.
So they say, all right, we're going to sign an affidavit. We're going to take him to the hospital. what happens after there's no real need to keep them in the hospital anymore?
Right. They're going to get dismissed.
And that's just going to be that.
Yep.
And then,
I mean, honestly, I've seen it so many times over the years,
yeah,
working in an ER when the police would bring somebody in and they'd be like, well, we want to have them evaluated for a hold. I mean, I've seen people who were actively suicidal who didn't get
oh yeah, many times,
admitted.
100 times.
Right.
Yeah.
So what you're saying, it's a nuisance. It's not an admission.
Not even close.
Probably not.
So like the idea being that we're going to be able to capture this population and address what the community ills, because that's what people are thinking. Like, I don't want the ice cream store broken into, and I get it. No one wants that.
No.
Totally understand. But the way the system currently is right now, it seems like it's not possible for this to be effective.
It isn't. Not the way it is now.
Yeah.
It cannot work. It will not work.
Yeah.
When you think about it, what the way it looks right now, you're literally just moving the problems and the issues from outside to inside for a temporary period of time and not working on the long-term solutions.
And let's talk about the cost of that. Beyond the the cost of the hospital system and the doctor and all that, which is going to be as high as you could possibly get. Psychiatric care is extraordinarily expensive. There are very few psychiatric nurses, and there's very few psychiatrists, so they can charge a premium for all of that. But what I want to talk about is the cost to the individual. Like, what long-term damage is done, especially in relation to the long-term outcome of this person getting healthy when we would involuntary hold right now. So this is around stigma, like the stigma of doing this.
So there's a huge cost to the morale of the individual. So if I said to you, Josh, I think that you're having a psychotic break, and you're like, no, I'm fine, and I'm like, no, I'm going to have you, admitted. I'm going to write this affidavit. Someone comes and sees you. So you're going to, number one, lose trust in me as your provider, potentially lose trust in the psychiatric team who's taking care of you. You're going to shut down a little bit with that. Maybe not give complete information about what is going on, what's happened in the past, because you've lost your self-determination. You've lost your right to choose care for yourself. And that is a moral injury to you. That is a moral injury to that person. So there's a huge cost to that individual person.
And I think the broader community is thinking, keep in mind I'm the voice of reason in this podcast. I think what the broader community is thinking is there's a cost to that break-in of that ice cream stall. Sure. There's a cost to seeing someone kind of wither away outside for years on end. So is the stigma that's going to happen to the individual worse than the stigma that's happening in the general public around the behavior of folks who have healthcare conditions that need to be treated?
Yeah, that's a really good question. So the problem with the individual, if the individual loses their trust in their providers, loses their trust in their community, then they are going to not follow up. They're not going to go back for health care, for psychiatric care. And so what you're going to see is you're going to see their mental health continue to decline. And then what happens to the community? I think that that's a great question, and we don't necessarily know the answer to it, but it's a temporary Band-Aid by doing this with no long-term solution the way it is now. And so the moral injury that occurs can have a domino effect on the community, because that person, you can't keep them there forever. They're not going to stay in that.
And I think this is what people need to
forever.
understand. So, like, if there's a thought that this system is somehow going to capture this problem and solve it, the current infrastructure doesn't allow for that to happen yet. It's not even close to ready.
No.
Like, even with inpatient, let's say someone desperately needed inpatient psychiatric treatment. How hard is it to get someone into that?
It's really hard. And part of that is
that's when you want to go.
Right. When somebody wants to go, it's very difficult. But you hit it earlier, like there aren't enough psychiatric providers.
Yes.
We know that mental illness, and just let's get this straight. When I'm talking about mental illness from a medical provider standpoint, that also includes substance use disorder. It includes alcohol use disorder. Those are all part of mental health. And the majority of our patients have some type of mental health disorder. Now, if you look at the statistics, they say 40 to 60%, but we've talked about this before. It's self-reported.
Yes.
Let me give you an example. We have a patient that we were helping just last week with disability. This patient is known to have severe mental health disorder. Went to do the disability determination on that form. Do you have a mental health disorder? No. Long-standing history, we all know it. The problem is the stigma around mental illness, number one. And when you're looking at those numbers, that 40 to 60%, it's self-reported.
Yes.
The data is not there. When you're talking about homelessness, we're missing a lot of data. There's a couple of reasons why. When we talk about medical, doing medical studies and research and things like that, there are certain populations that are widely excluded because of their ability to provide informed consent. So there are less studies on children because there is a little bit of an ethical dilemma around that. There are less studies on those who are mentally ill because are they really in a place where they can provide informed consent? On those who are homeless, because are you exploiting them by including them in studies? There is a board who the IRB looks at research and makes sure that it's ethical and that it's done in a way that is respecting individuals.
What I'm hearing is all of these rules prevent breakthroughs in medical science. We're just being held back here.
Well, it makes it difficult. It does make it difficult, for sure.
I'm messing around, obviously. Yes, some of the ethics...
But you're the voice of reason.
Yeah, I am. I represent the majority here, the very strong and learned majority that listen to this.
Yeah.
We have dozens of listeners. Yes.
Let's get it to 100.
Okay.
So that's where part of the problems come in, is because we don't know. We don't know. And getting those answers are difficult.
And let's onto the stigma. This is interesting. I think it's layered. So when you ask someone, do you have a mental illness? Why, especially if it's a stranger, why would you say yes?
They're not going to answer that. They're not going to answer that question.
You would
because who are you?
Who am I?
Yeah, who are you? Who are you to come up to me and say, do you have a mental illness?
You might as well go up to someone and say, hey, you're bad with money.
Yeah.
Right. Who are you? What? Who are? Even if it was true, you're going to be like, who are you? I'm not talking to you.
And a lot of those numbers come off the point in time count, because that is included in there.
100%.
And you have volunteers who are rarely out with those who are experiencing homelessness. There are groups like our teams go out and help, but okay, so what's your name? How old are you? Are you a veteran? Do you have a mental illness? Do you have a substance use disorder? They're going to answer no.
Yeah, and
they're going to answer no.
You are taught when you do these surveys, put down what they
have to put down what
they
answer. You can be looking at somebody who is actively in a psychotic break, dancing nude in the snow, and they say no, you answer no.
And so that goes into involuntary commitment. So if in their mind they are committed to believing and saying and portraying that they do not have a mental illness, when there's an involuntary commitment right now, that's still going to carry with them in there.
Right.
There's going to be resistance.
Yep.
Because there's built-in resistance on the street to admitting that this is a thing. So the culture of America in healthcare is issues with the brain are completely somehow different than any other issue that you have with your body.
It's a massive stigma. I tell patients frequently, and I have done this as long as I've been a nurse practitioner, when I talk to people about anxiety, depression, bipolar, and treatment, and for people who are resistant to treatment, I'll say, okay, if I told you that you had high blood pressure and that it was my recommendation that you take medicine for your high blood pressure, would you do it? The answer is a resounding yes. 99% of the time. It's a yes. So then my next response is, the heart is an organ. The blood pressure medicine is to help your heart function properly. And the brain is an organ. but you refuse to take medication to help that organ. And it's because of the stigma that is surrounding mental health, mental illness in America.
Yes.
And that's also one of the reasons why we don't have enough providers, because, you know, there was a time when nobody was going to see psychiatrists, psychologists, and now it is more talked about now. We're getting better. Well, we still have a long way to go. We still have a long way to go. Part of that is because it's still that stigma. I'm in the age group that we don't talk about Bruno, right?
Yeah. Oh, yeah.
You know, so I think that we have to continue to evolve, and we have to do it quickly, because what the
Yes.
involuntary admissions are not going to work how they are currently.
So that brings up the next question, KK.
What's the next question, Josh?
If it doesn't work, why are communities looking to this as a solution? And maybe I can answer that
Well,
as the
I
the moral
have-
arbiter
Yeah,
of this.
because people want an answer to homelessness.
Yes, they do.
That's the issue, and
Yes.
nobody has a good answer to that. Nobody has a good answer on how to end homelessness
But there is.
That-
you just don't want to do it.
that they want to hear about.
Yeah.
That's, you didn't let me finish, right? You didn't let me finish. I was in the middle
made
of
it-
the sentence.
Even better. That made it even better.
that's
Oh
the
my
thing.
God.
Yes.
Yes.
There
that
is an answer to ending homelessness,
Yep.
but people don't want to talk about it.
They want it to be free.
and they want it to be quick.
fast. Yes.
We didn't even plan that.
No.
Just say no.
It's just how it is.
No,
This
it's
is the
the
truth.
fact. So what you got? What's
All
your
right.
answer?
I think it's as simple as that. I think it's a couple things. I don't think people have become instantly discompassionate to this
Right.
population. I don't think that that's true. I think there are some, but it's not most.
Sure.
I think what people are thinking to themselves is, I'm watching someone die in front of me, die a public death at a bus stop or a park, sidewalk, thing like that. And they're going, I don't know how ethical it is to watch this happen. I don't think that is less or more. I don't think it's more ethical to watch that than it is to get this person involuntary help. Because in the mind of the viewer, of this person passing by, they don't understand the medical system is not equipped to handle this
Right.
at all. They're assuming, in the same way, if they broke their arm and went to the hospital, it'll get sorted out. Not only that, there's follow-up care, and you'll be good as new.
Let me break this down a little bit. How many people are living homeless in Kansas City? Let's just talk about the rough sleepers in Kansas City.
4,000.
Okay, 4,000. So let's say, just for grins, 50% of them have a mental illness.
Yeah, just 50%.
We both know that's not true, but we're going to go with the data. Okay, I understand, but let's
Just
just
letting
say
them know.
we're
gonna
just
take it
using this
easy.
as an example. So 4,000 people experiencing homelessness sleeping outside of Kansas City. 2,000 of them have a mental illness. How many of them are severely mentally ill that would need to be admitted under these new recommendations?
Let's say 200.
200. Where are they going to go?
Not in the state.
Right.
We'd have to shift.
So
out.
that's the point. Like, there's not the way we keep talking about, the infrastructure is not there. We're not talking about 3 or 4 people.
Yes.
We're talking about hundreds, and 200 is very
Conservative.
Yeah.
I went low, but it's still an astonishing high
It's
number.
a huge number, and there's no infrastructure
And don't just
in
think
the metro here
don't
or
just
in any
think
metro.
inpatient infrastructure. Don't just think that.
Right.
200 people means how many psychiatrists to do? And the psychiatrists already have a caseload this. Try and get an appointment with a psychiatrist right now.
Yeah.
It is 6 months from now.
Yeah.
So now add all of these folks with extraordinarily complex needs. They're going to need a lot more attention. If you really want to help, you got to put the time in. That's an investment in how many psychiatrists that don't exist.
Well, and not only psychiatrists, you've got to
APRNs.
have, well, you have to have the provider. Let's call them provider.
Okay,
So the nurse practitioner and the psychiatrist and the psychologist. Psychologists play an important role in helping in the system, the
Yeah.
mental health system in America.
Especially if you can pair them up with a prescriber.
Right.
Oh my gosh.
Right, which is what we do.
Yeah.
Anyway, but then you have to look at the support around those positions, because a psychiatrist, a psychiatric nurse practitioner, a psychologist, they're going to work directly with the patient. But if they're living outside, then who's going to help them with all of those other complexities?
So you're talking about an entire infrastructure set up around outreach and engagement.
Yep.
Follow up. So forget just the inpatient part. The follow-up part, there's no infrastructure for it.
None.
There's no infrastructure for any of this to be in place right now. The problem is people don't care.
Yeah.
They don't care.
Well, okay, look
I don't
at
blame
look at
them.
America. Look at America. Look how we are. We want instant gratification. This you get I'm mad at you, I'm gonna send you a text. Like I'm gonna tell you about it. I have a problem, I'm gonna pick up my phone. I have done that before.
It's great.
Yeah. But you
Tell me about it.
You have instant gratification in everything we do in America. And we have become a society where homelessness is very prevalent. And numbers are increasing. We've talked about that, like over the past 2 years, 15% increase in homelessness. 18. So you remember the number. He's better with numbers than I. 18% increase in homelessness over the past 2 years. It's not getting better. And so what we want to do is we want to fix the problem. And there's not a quick fix. Kansas City tried this a few years ago. Remember the hotel?
The Bartle Hall and Hotel.
The hotel initiative. Kansas City tried to fix homelessness in Kansas City. We were going to have 30 days, and we're going to put everybody in hotels who needs them. There were 14 throughout the city, I know, because my team went to every single one of them.
Yes, they did.
And during that 30 days, people are going to find housing, they're going to find jobs, and they're going to be fine. They did not provide any services. Now, they quickly rallied the troops and had organizations come in and help them. But initially,
it was ineffective.
It was ineffective, but it was because it was a response to an outcry.
Yes.
But the response was again a knee-jerk response that cost the city
millions.
Okay,
actual
millions of dollars,
and no outcomes to show for it.
No, because you can't get housed in Kansas City in 30 days. You can in Houston, yes. Right? We know that.
I will say that the failures of the look, I'll give him an A for trying. I'll give him a D- on
execution.
Yeah. And it did result in the city saying, we got to figure this out. And cities are going to continue to make this mistake. They're not going to understand how freaking hard this is.
Yeah.
But here's the deal. There is a clamoring from the general public to do something about this.
Yep.
And I can tell you this, for right or for wrong, the general public is not thinking about the conveyor belt that needs to happen to fix this problem. They are thinking, I don't want this anymore.
Right.
And the general public is going to win this argument. They're going to win. They're winning now. Even the most liberal, compassionate people are saying this isn't going to work. Someone who is on fentanyl, hardcore, loves it, can't get enough of it, physically dependent, do they have autonomy? That is what the general public is thinking. When they're seeing someone at the bus stop yelling at Abraham Lincoln in winter, their nose is going to fall off. Does that person have autonomy? They're thinking that.
Yeah.
And they have a point.
They do have a point.
I'm not the arbiter. I don't get to be the arbiter. I'm not even interested in being that. But they do have a point. So the next question, and among the most important, is what needs to exist for an involuntary hold system to actually be effective? Well, what if you got to design it? Because it's coming.
So I think we already talked about it a little bit, right? We have to have a stronger psychiatric provider network, and it has to include services that can help people move on to the next level. You're going to have, so say you have an involuntary hold. I mean, you have to think of it as there's got to be an end to it at some point. I don't know what that end is, whether it's 60 days, 90 days. What happens at the end?
Is it more than 72 hours?
Well, you cannot address
what happens in 72 hours?
Nothing. That's the thing. 72 hours is not enough. You might get people to get out of a psychotic break that they're having.
Like they'll calm down a bit.
Yeah, they're going to calm down.
We all need to
But you're not going to get them stabilized on medications in 72 hours.
So you're not going to get them to a point where they're making...
No, 72 hours.
No,
72 hours is not enough. And you're also, with like talk therapy and working through some of these things, it takes months, years to break down some of the complexities of the mental illness and what has gotten someone there. If we're talking about schizophrenia, bipolar, those kind of things, that's a little bit different than if we're talking about like people who have anxiety, depression from, maybe from trauma, whether it's childhood trauma or physical traumas that's happened to them. But you have to break those down. I mean, even people who have schizophrenia and bipolar, who maybe were diagnosed late teens, early 20s, there's also stigma around that. And so then there's the shame. And so there's a lot to break down a mental illness.
Oh, yeah.
And so you have got to have some plan long term. It's not, oh, they're going to be in the hospital. I don't care. 30 days, 60 days, 100 days. I mean, 72 hours is not long enough. Far enough.
Let's say the rule was a 45-day.
Okay.
Judge has to sign off for it. A series of events takes place to allow for that to happen. What kind of traction can you get in 45 days?
You can get some pretty good traction in 45 days. However,
how much does 45 days cost?
I don't know. A lot.
I mean, $50,000.
Oh no, I don't know in a psychiatric entry.
So when I worked I worked at a place that did inpatient youth.
Okay.
Youth psychiatric residential facility.
Okay.
And this was 15 years ago.
Mm-hmm.
$500 a day.
Okay.
So I can imagine it's that or more.
So let's just say 50,000 for 45 days. That's really probably way lowballing it. But
I agree. I think it's going to be way more than that.
Let's say that. But you can get some traction. However,
I want to spend $50,000. Like society. I know you want this.
Okay.
Is that to that tune?
What happens at the end of the 45 days?
We write a check and then.
No. I'm not talking about money. I'm talking about the person, because you're the voice of reason.
So I think the hope is after 45 days, and let's say it's someone schizophrenia. My brother had it. It sucked.
Yeah.
It sucked. When he was medicated, he was great.
Sure.
When he wasn't, it was scary.
Sure.
He wasn't violent or anything like that. I'm just scared for his life.
And hard for them.
Oh, it's awful.
For people who have schizophrenia, it's really hard to watch. It
sucks.
So hard to watch.
Yes, it's brutal.
It is. Okay, so at the end of 45 days...
Can they make a decision about what life looks like after 45 days?
You have to even look simpler than that. Where are they going at the end of 45 days? They came from a camp down the road. Now...
I think the hope is, okay, so if you go to the in-camp, before medical treatment, and you ask them, what does life look like? They're not, are they really giving you an answer about the trajectory of their life, or is the mental illness talking?
Well... The other thing about that in doing this over the past 10 years is that the people that we take care of cannot think past the next few minutes.
So shouldn't someone make those decisions for them?
That's a really difficult question.
So in case management, one of the things I tell case managers that I don't have them now, but I used to manage them. I would say your job is to have better judgment than your client. Period. Doesn't mean you're making decisions for them. It means you have to have better judgment than them.
But what we have found is if you can work alongside people, and you know this, aggressive engagement,
you got to earn it.
You have to earn that trust. And a lot of times, if you can work alongside with them, be consistent, be the voice of reason, people can come to the realization this isn't where I want to be. This isn't what, I do want to get help. I want to get treatment. But it's not like you're going to walk into an encampment and go, oh, you have bipolar disease.
Come on to the car.
Let's go.
Let's go.
Right. And so it's earning that trust.
Could a shot do that? Could an invasive medical system or treatment or process get them to make that decision quicker?
Well, so as things stand right now.
No.
Well, you can't do that. I can't treat a patient without their consent.
Right.
Now, if it's an involuntary hold, that's different. It's a little bit, but it's also
pretty limited.
Yeah. It's very limited, right?
Yeah.
That's assault. If I walk up to you and go, hey, Josh, and give you a shot of whatever, give you, some kind of medication, and you did not give me permission to do that, you can sue me for assault.
So really what we're talking about with involuntary holds is, at what level is that intervention going to be okay? And I think you set it up really well there.
Yeah.
Imagine walking up to someone with a syringe full of medication and going, here's some Christmas cheer.
Yeah.
That's a big decision.
Yeah, it is. And the way things are now, you can't do that. But if we talk about say there's a 45-day involuntary hold, because that's what we're using, right? And I'm not looking at the cost.
It's just phenomenal that people think that this is a manageable solution. Like they don't want to pay for housing, but they'll pay it's insane.
No, you're right. You're
it
right.
makes no sense.
However, what
the hell are you thinking about that this is going to work? You don't want to pay for homeless services, but you're willing to pay for this. You're paying triple for this than to get someone out of homeless. This is insane.
But at the end of 45 days, where are they going? Back to the encampment, because that's where they came from. They don't have a house.
But the thought is, after the 45 days, they're going to think differently about their life. They're employable at that point.
Not going to make that. I'm not disagreeing with you.
In 45 days to get them to that?
Well, yeah.
So
it's possible to get them to that thought process, but it's not possible to get them there. We just talked about the housing crisis in America. Where are they going to go? Because they've been homeless, and then they've been in a hospital 45 days. They don't have a job. They don't have housing. It's so in some cities they can get housed pretty quickly, not in ours. And if let's just say how we know that this works with our patient population, they're not going to have an ID. They're not going to have a birth certificate. The hospitals don't get those things for people, right?
Newsflash.
So yeah, they can't, and I don't blame the hospitals for that.
It's not what they're designed.
It's not what they're designed.
In the same way, they're not designed to help you get a mortgage. It's not what they do.
So while they're there for 45 days, their thought processes may be different. But what you're going to do? You're going to send them back to the camp where maybe they have difficulty following up with their psychiatric provider. Maybe somebody is like, "Hey, I have some drugs." I mean, you're going to send them back to the streets where they were. They may have a different mindset. They may have a different goal. But then when they get back to the streets, their goal is survival.
So what you're saying is, not only is the healthcare infrastructure not sufficient to address this, this can't be done in a vacuum. And currently, even if we build out the medical infrastructure necessary to do this, and I believe that we will attempt to do that, I think there's enough momentum here that this is going to happen on some level.
Okay.
The aftercare infrastructure needs to be just as robust and available, and it does not exist.
Well, aftercare, and if you want
aftercare, I mean housing.
Yeah, no, I know. But if you want it to be successful, you're going to have to embed those wraparound services in the 45 days.
Oh yeah, it has to all be.
Yeah, you have to do that during the time that they're there, because what we know, we have a medical respite facility, as you know. Yeah. Our medical respite facility shows how this can work. 50% of our patients who leave medical respite do not go back to the streets. Because
50%.
50% over the last 2 years. Nobody else has those numbers.
So a chronically homeless individual is going to cost your city about $60,000.
Right. And we're free. Although, whatever.
Well, that's to remain homeless.
Yeah, exactly. So that is just a tiny little sampling of how, while they're there, so when they're with us, we're low barrier, but they're with us for medical care. While they're with us, we provide wraparound services. That's what's going to happen in psychiatric. If we resort to involuntary admissions for more than 72, 96 hours, because those numbers don't work, we're going to resort to that. Then we're going to have to also provide those wraparound services. So at the end of those 45 days, and 45 days is not very long in our city, it is effective in other cities. But if we're going to look at 45 days, you've got to have the services in place within the psychiatric facility to support them on that discharge date. Where is it you want to go at discharge? Okay, so we can get you housing. We can help you, get your birth certificate ID. You've got to have all those things, because if you don't, it is another hamster wheel that our patients get on. Our patients are continually in a vicious cycle of homelessness. And this system, putting them in involuntary admissions is not going to change that vicious cycle, because we have all of those other social issues that are leading to them being homeless.
And I don't think any of that logic is going to penetrate the general public at this point. It is, and look, I get it. People are really tired of the behavior, but I think at the heart of it, I really do believe this. People are tired of watching people die outside of jail. They're sick and tired of it. They think it's insane that in America we're doing nothing about it. And I also think it's important to note, we make involuntary medical decisions or involuntary decisions about family members all the time.
We don't.
All the time. Yes, we do. When we take the car keys away, that is an involuntary decision.
Well, but that's not a medical teams don't do that.
what I'm talking about is families.
Families, yep.
Families will also say you need to go live in a nursing home or you're going to have a nurse come to the house, oftentimes against the will of the individual. The difference with someone who's chronically homeless is they don't have a family member making those decisions for them. And that, what we're saying is because they don't have a family member, we're not allowed to do it at all. And I think that is where there's a huge disconnect between how the general public feels this and views this, then possibly the medically, but certainly the homeless activist advocate group. They, for some reason, draw a line. And because you don't have a family, we can't even discuss this. Even bringing it up, oh my gosh, the amount of pushback you get on this topic is phenomenal.
Yeah,
I think that's bad logic.
Well, I agree with you. However, I will say from a medical standpoint, that if families want something done or not done to or with a family member, if the family member doesn't agree, it doesn't just happen. That doesn't, like, I can't go in and say, if my husband has, some kind of medical problem and he doesn't have a durable power of attorney living will, and I say, well, I just want you to, stop doing what you're doing. They don't just stop. There is a process. If I take my husband to the ER and I say, I want him, admitted for a psychiatric evaluation, it doesn't work that way.
Oh, I know.
And
but you in this thought experiment, you're the one driving this. Someone experiencing homelessness has no one driving it. What we're saying is no one should drive it. And I think that is where we have gone wrong. We absolutely need to have these discussions, not the least of which it's coming, so we better be prepared.
Sure.
I think it's also important to note there's no way the federal government can implement this. It's not possible. No. They don't have the people, they don't have the money, they don't have the infrastructure. They're going to be completely dependent on what this looks like locally. So, communities across the country, stop waiting for this to be implemented. You get to decide what implementation looks like on this. You get to decide. It's why we're having this conversation. KK should be central to this conversation in Kansas City, and wherever you live, whoever you are, and whoever needs to be central needs to be. But we have to stop talking about it. I think there's stigma in even bringing this up, especially among homeless providers. Get rid of that stigma. In the same way stigma on mental illness exists, we have to have an honest conversation about this. We have to, because it's not working the way it is now.
No.
Do we have questions? Do we have ask the expert questions?
So we can't have, we can't do this podcast without mentioning Jackie Lamer. What question what you got for us today?
I'm going to start with Josh, because you've been spelling out the point of view of the broader public, the point of view of hospital
reasonable people,
administrators, reasonable people. Clearly, each of you have your point of view, but I haven't heard anything about the law enforcement professional. So can you lay out the point of view of a law enforcement professional, please?
Perhaps. I'm not one of them. I think on I don't experience what they have to experience every day. I think perhaps they just want a solution. When they roll up on a situation, on a 911 call of someone at a bus stop losing it, they want a place they can take that person. I think at the end of the day, that is what they want. They are not thinking about the long-term health because they got another call and another call and another call. Right. They are really a conduit to what's next. I can imagine that they're going to be happy with any resource that they can use to help that person. That is my opinion on likely what law enforcement is thinking. I imagine they'll have different opinions too. It's a good question.
Okay, thanks. KK, you talked a little bit about the care house, and it seems like maybe we need to know a little bit more. It seems like the care house is almost a solution for Kansas City in terms of involuntary admissions.
It's not. So we're not, we are not equipped to do psychiatric evaluation. We do have a psychologist and we have a psychiatrist, but that's not the crux of what we're doing. We are doing physical medical care. And for
a
good example is I'll give you a good example. Someone who has had their toes amputated because of frostbite. And oftentimes those individuals need ongoing wound care. When you have your toes amputated, they generally like to
do they grow back?
No, they don't grow back.
This isn't an eyebrow. Breaking news. Okay.
This isn't your fingernail. But you need to be off of that foot for healing for weeks.
So it grows back.
No, so it heals without opening back up because you have stitches on the end of your toe. And, think about it when you're walking, you put pressure on it constantly.
Imagine having an amputation and then going camping.
Right, exactly.
It's going to get infected.
And trying to navigate. So people are not supposed to be putting weight on it. My husband just had the end of his toe cut off.
Yeah.
In October. And he had to be non-weight bearing, completely non-weight bearing for 2 weeks. So
you can't do that outside.
You can't do that.
Will not live.
So he has a knee scooter. A knee scooter cannot go down hills in
half a mile in the woods.
And when he's not using the knee scooter, then he used his crutches. Great. You can't do that when you're living outside. Number one, you can't keep it clean. A lot of times they like to have the dressing stay on until your post-op appointment, and you need to keep it clean and dry. Ooh. You're living out in the mud, out in the snow. That doesn't happen. So that is one of the things that we do is a lot of wound care. Take care of people who have open wounds, people who need IV antibiotics. We really are post-acute. And when you're talking about psychiatric illnesses, that's not something that's post-acute. It's chronic. We get a lot of calls from hospitals saying, hey, this person has congestive heart failure and they need help managing their medications. That's really not appropriate for respite. Now, one would say, well, they have congestive heart failure. That's true. But what happens at the end of 2 weeks when we've helped them with their medication? They're still going to have congestive heart failure. Whereas opposed to having a wound, needing IV antibiotics, there's an end to it. Now, as we grow, we're going to be bigger. Maybe we should talk about medical respite at some point.
Yeah.
But we're going to have more beds and be able to we're going to have a little more flexibility in that. But right now, we are not a psychiatric facility, and we're not equipped for that. It would be like us saying, okay, well, can we take people with ventilators? No, we're not equipped for it. You really need the specialists taking care of people with those psychiatric disorders to take care of them. Can we handle people who have co-occurring psychiatric disorders? We can. Join us next time on Untangling Knots, where we'll...
That's a wrap.
No, don't say that. Don't say that. Where we'll continue to explore the complexities of homelessness without the sugar coat.
We get real here, baby. Thanks for watching.
Sugarcoat anything.
We'll see you on the next one.
Yes, we will.
There we go.